Good morning. I am Dr. Srilakshmi PS from Department of Conservative Dentistry and Endodontics. Today the topic of discussion is apexogenesis and apexification. So this is a chart representing the tooth eruption sequence of all the teeth, and we have to note that the root formation occurs 2 to 3 years after the tooth erupts. So this is the chart wherein it shows us various developmental stages of root formation. Now, what is an open apex? Open apex can be defined as an unusually wide apical foramen of a root, making it challenging to prepare an apical stop during a endodontic treatment. How does open apex happen? It can be due to an early cessation of root development, external or internal root resorption, excessive instrumentation or perforation, caries and trauma that are most common causes of apical necrosis, pulpal necrosis, orthodontic treatment, or a periradicular inflammation and other developmental conditions like dens invaginatus can also cause a open apex. Now, these are the classification of the open apex or immature tooth. So the walls can be either divergent, which is called as a blunderbuss canal. It can be parallel, or it can be slightly convergent, or it can be even tapering. Apexogenesis. The indications of apexogenesis is mainly in a immature teeth which has a damaged coronal pulp and a healthy radicular pulp. Treatment of vital pulp, which is an open apex. You can do either partial pulpotomy, which is also known as Sweck's pulpotomy, and full pulpotomy, which is also known as cervical pulpotomy. So these are the diagrams of partial and Sweck's pulpotomy. What are the contraindications? Pulpotomy or apexogenesis cannot be done in avulsed or severely luxated tooth, crown root fracture, horizontal root fracture, unrestorable tooth, and necrotic pulp. Now, what is apexification? Apexification refers to the root enclosure. It is usually done in an immature tooth with a necrotic pulp. This technique involves cleaning and filling the canal with a temporary paste to stimulate the formation of calcified tissue barrier at the apex. The temporary paste is later removed after radiographic evidence of apical closure has been obtained and a permanent filling of gutta perca in the root canal is done. The rationale, poor long-term prognosis of endodontically treated immature teeth, relatively thin dentin in obturated canal of incompletely formed roots and open apices are at risk of fracture. Pulp revascularization and repair will more readily occur in teeth with a wide apical foramina. Pulp of immature teeth has a significant repair potential. Now these are the steps of apexification using calcium hydroxide. Once anesthesia is given, rubber dam isolation and access opening is done. Working length 2 mm short of radiographic apex is taken. Circumferential enlargement using lateral pressure against the walls with a larger filing is done. The canals are dried with paper point and then calcium hydroxide is applied into the canal in a thick consistency. Paste is delivered into the canal with an amalgam carrier and condensed with finger plugs. The entire canal is filled with a calcium hydroxide paste in contact with the periapical tissues. Access cavity is then sealed with RMGIC and the patient is recalled after 3 months to observe radiographically for a calcific barrier. If a calcific barrier is obtained, the patient is then fit for obturation with thermoplasticized GP. And if the calcium barrier is not formed, then we have to wait for another 3 more months till evidence of calcific barrier is seen. These are the diagrams for apexification using calcium hydroxide paste. Calcium of the apical barrier comes from the blood. Long-term use of the intracanal calcium hydroxide can cause weakening of the root dentin leading to its fracture. Every effort should be taken to preserve any vital apical pulp tissue that will help the closure of the immature apex. Apexification is usually completed in 6 months to 2 years at the maximum range. Now you can go for a single step apexification with the help of MTA or biodentin. MTA has a good biocompatibility and has a better ability to seal and produce superior barrier. Simple and more effective in creating an apical barrier. So the techniques are, first, anesthesia is given to the patient, rubber dam isolation is done, and access opening is done. Working length 2 mm short of the radiographic apex is taken. Circumferential filing is done. The canal is dried with paper points. MTA is then mixed in 3:1 ratio and or biodentin is used according to the manufacturer's instruction, and it is delivered into the canal and condensed with pre-fitted pluggers. Material is then condensed into a 3 to 4 mm apical plug. Moist cotton pellet is placed over the MTA and the patient is recalled in the next 48 hours and the set MTA is then verified. Once the MTA has been completely set, obturation is done using a thermoplasticized technique. These are the diagrams for apexification using MTA or biodentin or any other calcium silicate based materials. Contraindication: apexification cannot be done when there is a horizontal or vertical root fracture, there is replacement resorption, very short roots, vital pulp, marginal periodontal breakdown. So this is a radiograph of the follow-up X-rays. Now this is the difference between apexification and apexogenesis. Apexogenesis is a physiological process, whereas apexification is a process wherein we induce development of the root apex in an immature pulpless tooth by formation of osteocementum or other bone-like tissues. Apexogenesis, when you do an apexogenesis, the pulp is either normal or with minimum inflammation, whereas in apexification, it is a completely necrotic pulp. So in case of an apexogenesis, normal root development take place, whereas in apexification, it does not take place, and most commonly, a calcific barrier is formed. Thank you.